thing for us to try to do in an effort to try to illustrate some of the things that I'm about to show you guys. I thought y'all would like that better than just stand up and do some jumping jacks, which we can do that in a minute too. That will get some heart rate, okay? So what I've got here, guys, we're going to walk through probably for most of the day talking about cardiac output and how we modify cardiac output by changing either heart rate or stroke volume, or in some instances, both. Okay? And so we're going to start with the more straightforward one. Okay? You guys all had some resting heart rate, right? You were here, look at your watch, there was some kind of a heart rate, right? Anybody in the 50s? Anybody? You guys are in the 50s? No? And we're sprinting here because you were late. We're going to talk about that, guys. Right? I feel like we're getting some bad stragglers on all of that. In that way, since spring break, we're going to get a little lackadaisical there. Okay, so there are some things that control your heart rate. All right. Remember, heart rate originates in the SA node, right, in the right atria, and so the SA node will respond to different signals. It will respond to input. Okay, and we'll talk about what that input is. Some input makes heart rate go up, some makes it go down. Okay. And we were attempting to manipulate those things with the breathing and sharing of facts and those kinds of things. So let me see if this will actually advance forward. Okay. The reason I asked if anybody was like down in the 40s or the 50s, some of you guys probably should be if you get you really rested, is we all have, right, the intrinsic firing rate in the SA node somewhere between 70 and 75 beats per minute. Okay. Many of you will have a resting heart rate that is lower than that intrinsic firing rate. Okay. If we turn the lights off, we let you lay down, we let you get really, really calm, right? We put on some nice soothing like rainfall or something in the background. We could probably get you calm enough to lower your heart rate below that intrinsic firing rate. So what that illustrates is that in a lot of instances, the things that lower heart rate tend to predominate at rest. Okay? Now, as you become less in shape or more stressed or more anxious, like I am chronically, your heart rate tends to go up. Okay? A lot of you may be compounded by the energy drink that you have, or coffee that you're drinking, or something else, which is some other interesting things. Okay? We see normal ranges in folks, highly trained endurance athletes, maybe down into the high 40s, into the 30s. Okay? Very, very low. And then we see some folks that are in the 90s to 100, somewhere kind of thereabout. That's the regular range that we're going to see. Okay? The good thing about heart rate and its impact on cardiac output is it's a really good predictor, as you guys have probably already seen, of exercise intensity. As heart rate increases, cardiac output increases, which means that's going to correspond to an increase in oxygen consumption. So the increase in heart rate corresponds to an increase in metabolism, which likely corresponds to an increase in muscular work. So we can use heart rate as a surrogate or a way to predict exercise intensity with pretty good accuracy. Okay? We'll walk through how we do that in a little bit. Okay? The cool thing about heart rate, unlike oxygen consumption, is if I ask you guys to start walking or jogging or doing something, is that heart rate goes up immediately. And it will level off and plateau within about 10 seconds if the work rate stays the same. Remember, it takes oxygen consumption a couple of minutes to go up and plateau. So heart rate will stop and plateau well before that sort of lag in oxygen consumption can catch up. Okay? So it's really, really useful in that way for us to have these kind of monitoring quick changes in exercise intensity. Okay. Another important variable that I know you guys have seen is every one of us has a physiological maximum in our heart rate. Okay? Most of you are somewhere around 20-ish, give or take a year or two here and there. Okay? The easy way to calculate max heart rate is it's 220 minus your age. So most of you guys are going to be somewhere around 200-ish in your max heart rate. Okay? That's age predicted max heart rate. Me, screaming towards 47 at a surprisingly alarming rate in a few weeks, my max heart rate is not going to be 200, right? Mine's going to be, all right, do the maths in my head. 170, about to be 173, or somewhere in there, okay? And so because of that, just by being old, okay, just by being old, as Ellis likes to call me, I have less ability to increase cardiac output than you guys do. And if I have less ability to increase cardiac output, I likely have a smaller VO2 max, all other things equal. Okay, so max heart rate is stable with exercise training. Weirdly, in really well aerobically trained people, very often they have a hard time achieving their age predicted max heart rate. They're so fit that they can't even get their other systems are going to fail before they can max out the cardiovascular heart rate response. Okay, I do want you guys to know this equation. There are other max heart rate equations because we're researchers and we're never happier than taking something that works perfectly well and trying to make it ever so slightly better in the hopes that we will become famous. Okay, and so you can use 206.9 minus basically 2/3 of your age. And in some populations, you get a number that's within like 1 or 2 beats per minute of the 220 minus your age. It really couldn't make the least bit of difference. But we need to know this because that's going to come back. Okay, max heart rate's going to come back and be important as we continue to talk about maxing out cardiac output and those things and how we change it going forward. Okay. All right. One of the primary ways that we control heart rate is through something called the autonomic nervous system. Okay. The autonomic nervous system includes sympathetic and parasympathetic nervous system input. When I say sympathetic, somebody tell me, what do you think of? Sympathetic response. Fight or flight, very good, right? I'm going to have to run away or I'm going to have to fight, right, on whatever this thing is. Parasympathetic, what do we often call parasympathetic? Rest and digest, okay? So generally, parasympathetic predominates much more so at rest, okay, when you're not doing things. And then sympathetic input is going to come in either when we begin to exercise or if you're in some sort of situation where you perceive a threat, stress, or something like that. Okay? So what we know is the sympathetic nervous system will release epinephrine and norepinephrine. Technically, to the SA node, they're neurotransmitters, they're not actually hormones. Again, it doesn't matter. Okay? Epi and norepi on the SA node make heart rate go up. Okay, they make heart rate go up. The parasympathetic nervous system releases acetylcholine. If I bathe the SA node in acetylcholine, heart rate comes down. Okay, your heart rate comes down. So when we were trying to turn the lights off and do that breathing exercise, it is going to reduce epinephrine and norepinephrine release and hopefully promote acetylcholine release, which then brings your heart rate down to wherever it is at rest. Okay. If the intrinsic firing rate is 70 to 75 beats per minute, and your resting heart rate is lower than that, that's indicative, right, that there is essentially at rest no sympathetic input and additional parasympathetic input to help us get below that area. Okay. But that's what we're going to have. When I tell you this is a fun thing, okay? if I say, everybody, are we ready? We're gonna squat in 3, 2, 1. You've all released epinephrine and norepinephrine, and you haven't even done anything. Okay? There's what's called an anticipatory increase before exercise. If you tell someone they're about to exercise, that will release epinephrine and norepinephrine or remove acetylcholine, and it will immediately begin to raise the heart rate. You don't even have to start moving. Okay? So same thing when we put you in a stressful situation, which I thought you all shared in your embarrassing facts. To me, with the anxiety disorder, it's like, no, we don't share. No, avoid that. Okay, y'all are out there with things, making TikTok videos about it, which is great. Y'all are much more mentally healthy than I am. Okay, on all of that, that should release epinephrine, norepinephrine, and begin to raise heart rate. Okay. When we control, let me go to, I think it's on the next slide. I feel like there's a really good graph. Okay. I want you guys to focus on this. Okay. Focus here, and then we'll walk back and talk about what happened. So what you see here on the x-axis is percentage of max VO2. So this is exercise intensity on the x-axis. The y-axis is heart rate. Okay. And what they have graphed on here, while it's not 100% sort of bang on accurate, does a really nice job to me of illustrating how we attempt to control and manipulate heart rate as exercise begins, as we progress through higher and higher intensities of exercise. Parasympathetic input to the SA node comes from the vagus nerve. So at rest, you have heightened vagus parasympathetic input to the SA node, which lowers heart rate from its intrinsic rate down. As you begin to exercise, so as you go from sitting to stand up and start to walk, in many of you, what will happen initially is we will stop releasing acetylcholine. You'll remove parasympathetic. We've not yet begun to put sympathetic on top of that. We just remove the parasympathetic. So as that declines, heart rate rises. Okay. And we will reach some tipping point here where we basically turn off the vagus nerve. And we then begin to add sympathetic on top of that. And so we get an increase early in exercise simply by removing parasympathetic, and then a further increase as intensity clears out here. You can see that, I mean, this is at basically like 30% or something. So it's barely, having to walk even kind of just moderately fast, and you're going to basically stop having parasympathetic and begin to have sympathetic. Okay. Now, technically, there's always this balance between the two. It's kind of like metabolism. There's always a little bit of epi and norepi and a little bit of acetylcholine. It's kind of always being released. It's just which one is predominating. So I don't want to make it seem like it's absolutely this cut and dry, but that's how we control heart rate. Okay. Move vagus tone early on, add sympathetic as we increase intensity. Okay. All the way up until we reach max heart rate. What I want to point out in the top part of the slide, okay, is what you will note is that in purple, the vagus nerve innervates the SA node and atria, okay, and then the sympathetic nerves, of which there are several, and we're not going to get into all of those kinds of things. They provide input to the SA node, the AV node, but then they also provide input onto the ventral. Okay. When we get to talking about the regulation of stroke volume and how hard the ventricles can contract, the forcefulness of their contraction, especially norepinephrine, is going to act directly on the cardiac muscle. And so it's going to make the heart rate go up, and it's also going to make the cardiac muscle contract more forcefully. So it has some additional effects that we'll get into in a few slides. Okay? Does this make sense? If this does not make sense, then we're going to have problems. Okay? We're going to have problems going forward. seeing anybody expressing a problem. We'll. All right, let me make sure that I didn't miss anything that was going to be here. Nope, we got that. Okay. So again, you're not really responsible for this, but I pulled this from an older exercise physiology textbook that I think it does a nice job basically of talking about that anticipatory response. Okay, how we activate an increase in heart rate, what the response is. Then during exercise, we withdraw parasympathetic, okay, we increase sympathetic, and that's going to get us these alterations in sort of response to these alterations in different ions, and especially into PCO2 and PO2 levels and all of that. Okay, you don't have to know all of this. I just want to provide it for context, okay, for how and why things are regulated the way that they are. Okay, so that's one way. And one of the primary ways that we control heart rate. There are others, though, okay? There are others. Don't hit your neighbor, but put your arm out. Can all of you sense that your arm is out in space somewhere? Right, like it's here. All right. Doing this, now put it up. You feel this over your head. Now bend at the elbow. All right. Do the tricep, whatever these things are. Move your head. You all see the people at the gym? I don't want to pick on anybody, ladies. We're doing tricep things like this, right? We're basically just dropping the weight, doing all of that. You gotta get them back like this. Anyway, so it's fine. It's fine. Again, I'll just make a video. We'll demonstrate on those kinds of things. Okay. You have right. Those proprioceptors that tell you my arm is out here, I'm bending at the elbow, my shoulder is in this position, my hand is in this position, okay? Proprioceptors in your joints that sense position. Those things also are going to play some role as you move in raising heart rate, okay? Because it knows that as we move, we have to generate force that costs us energy. If it's costing us energy, we should probably ramp up cardiac output to bring more oxygen and glucose and things to our muscle tissue. Okay, so there are receptors in joints, receptors in muscles. There's also receptors in blood vessels. Okay, that sense position. So mechanoreceptors, they sense that we're moving. There's also some that sense chemicals. Okay, chemoreceptor. And they're also going to play some role in helping to raise heart rate. Primarily, what we're trying to do is to match oxygen in the blood and CO2 in the blood to what we need at skeletal muscle and what we need to remove in the lungs. Okay, so there's this nice kind of connection between changes in heart rate and cardiac output, as well as changes in breathing, to try to match oxygen and CO2 to where we want them to be. Okay. If you'd like to learn more about that, Dr. L21 is graciously teaching a PhD level class in cardiovascular physiology next fall. If you're around, he will be happy to blow your mind with all of the fun sort of responses on those kinds of things. Okay. All right. I don't know why this part of stroke volume is up again. I must have missed that. But that's how we regulate heart rate. Okay, here we go. So now let's talk about stroke volume. Okay, talk about stroke volume. Heart rate's easy. Regulation of heart rate is easy. You start to exercise, it goes up, it's a pretty linear increase, right? All we're doing is taking acetylcholine away, adding ephedrine, norepinephrine for the most part. Very nice, kind of clean regulatory system. Okay. As you can see from here, to regulate stroke volume and its changes during exercise, there's four variables, four things we have to consider with multiple things underneath. There's something called preload, there's something called afterload, there's contractility of the ventricles, and then heart rate itself actually has some effects on stroke volume. Okay. I think I told you guys on Monday. All of you all are roughly the same age for the most part, okay? And so if the person in class who has the largest cardiac output relative to their body size will likely have the highest VO2 max. Okay? If you're all roughly the same age, then you can all increase cardiac output by increasing heart rate to roughly the same extent. Okay? You can all get to 198 or 200 or somewhere there. So heart rate regulation just kind of happens and is somewhat less important in determining fitness differences and cardiovascular function differences in people that are roughly the same age. So what that leaves us with then is stroke volume. And the person in here, per their body size, okay, that has the largest maximal stroke volume will have the largest VO2 max, so will have the highest VO2 max. The most fit person in class. We need to look around again, like we did on the first day of class, in a very non-creepy way, and be like, do we think truly fit? Right? What you're saying to that person is, I think you have a really big stroke volume per your body size. Okay? So we'll talk about how each of these variables are going to contribute to how much you can increase stroke volume. Okay? The first one is something called preload. Okay? Preload. Have you guys heard, do y'all talk about preload? Have you seen it all in human phys? Yes, you've heard of preload. Another name for preload is end diastolic volume. Preload is the amount of blood in the left ventricle at the end of diastole. How much blood are we going to fill the left ventricle with right before it begins to contract? Okay? And so the more blood that we can put in the left ventricle, the more we have a chance to eject out every time we breathe. So I'll walk us through a few of the things that are going to contribute to preload. Okay? All right. Preload is sometimes called end diastolic volume, right? In old textbooks, it was called end diastolic pressure. All that means is if you were, as end diastolic volume increases, the pressure of the blood pressing against the inside of the ventricle, it's going to go up. It's all the same thing. Okay? As preload goes up, a fun thing happens in the left ventricle. It's just like the ventricle is going to do a vertical jump. Okay? Anytime we're going to do a vertical jump, what's the first thing that I do? Right? I go down. I stretch my quads. Then I can get a stretch shortening cycle and I can get more force. So as preload goes up, okay, we stretch the cardiac muscle. We stretch any of the connective tissue in the cardiac muscle. And as it stretches, that through something called the Frank-Starling mechanism or the Frank-Starling law of the heart leads to an increase in the contraction strength, which leads to an increase in the amount of blood that leaves the heart. Okay? So every time we put more blood into the ventricle, it stretches. It's just like a person sinking down before they jump up. Okay? So increased preload equals increased stretch, which equals increased stroke volume. More stretch, more force. More force, bigger stroke volume. Okay? Should I do one thing to every one of you guys right now and immediately make your preload go up? Anybody know what it is? One of the gymnasts in class can do a handstand. We all know. Right? Posture. Posture, right? Right now, right? Gravity is working sort of against him in this particular way. When you feel lightheaded, right? What do we have people do? Anybody had first aid? Somebody feels lightheaded, it feels good. What's the first thing we have them do? Lay down, right? Prop your feet up, get in resting position. Okay? Lay down, prop your feet up. Most of the blood in my body right now is in the veins in my legs. Gravity's pulling it down, keeping it from going back to my heart. I lay down, prop my feet up, remove the gravity effects, we get more venous return, more blood comes in, I get a bigger preload. Okay? Preload means bigger cardiac output, it's gonna help us get oxygen to our tissue. Okay? You do the same thing. You invert yourself, now gravity's helping you get blood back. Okay? So that's the big thing about preload. Okay, more preload, more force, more stretch. Okay. So what this slide is going to try to outline, I'm sorry you guys are just going to have to memorize these things, is there are factors that affect how much preload we get. Okay. And those factors are going to be cardiac output, or what we call venous return. Okay. So the amount of blood coming from the veins through the superior vena cava during diastole back into the heart has an effect. If I can increase the amount of venous return, I can make preload go up. I can increase venous return, preload goes up. Okay. Anybody run a race? You like a 5K or anything else? And you feel really shitty at the end? What are you supposed to do at the end? It's not lay down and prop your feet up. Right? As much as you might want to. What are you supposed to do? Somebody said it? Walk. Why do you walk? You squeeze the veins in your legs and it increases venous return and maintains the account. So venous return, okay? The other thing we can do is I can give you more blood. Okay? Larger blood volume means more venous return. Larger blood volume means larger preload. One of the biggest adaptations to aerobic training is you get more blood, which makes your stroke volume go up. Okay. One of the reasons it is difficult and that VO2 max goes down during exercise in the heat is as you dehydrate yourself, your blood volume falls. When the blood volume falls, venous return falls, stroke volume falls, cardiac output falls, VO2 max falls. It's all interrelated. Okay. The muscle and thoracic pump, that's what I talked about, the muscle pump. When I contract my leg muscles, I squeeze those veins and it sends more blood back to the heart. That's why you've been doing, especially high intensity exercise. Okay, you never stop right when you're done. Okay, you never stop right when you're done. You'll pass out, you'll get lightened because you remove that, venous return falls. Posture matters, we talked about that. Another big deal, but we don't talk about very often, it's really important, is heart size. Little heart size, right? Anatomical heart size. There's another argument that people make that whichever one of you has the largest heart and therefore the largest left ventricle per your body size will have the largest stroke volume and will be the most fit. Okay? So a bigger left ventricle means more blood can get in there, larger stroke volume. Okay? So I can make blood volume go up with training. I can make heart size go up with training. That's going to help me raise stroke volume. It's going to help us have larger cardiac output and larger VO2 max later on. Okay, but essentially all of these things, blood volume, the muscle pump, posture, okay, all are going to play a role in affecting venous return. Heart size kind of functions by itself. Venous tone, I like to talk about venous tone because it gets us in trouble, right? You can sort of control the diameter of your veins a little bit, not nearly as much as you can in your arterioles. And so that can kind of get us in trouble. But most of this is you increase venous return, you have a bigger heart, you get a bigger preload, and you get a bigger stroke volume. Okay. Okay. I talked about those. I want to mention one other thing that we haven't really talked about. Okay. Did you guys do a dissection of a vein? Y'all do that in anatomy? They show you guys pictures of those. Like I can get to cut one open and see sort of what it looks like and see if it has smooth muscle around it or see the valves inside or anything else. Okay. So veins have some different structures than arteries do or capillaries. Veins have structures called valves. Okay. And what the valves do is they prevent the backwards movement of blood. So once blood gets to a certain point in a vein, it can't go backwards. So even though gravity's trying to pull all the blood down into my legs, Once I get it, say to my hips and femoral artery or the femoral vein, it's not going to go any farther backward. It can only sort of move forward. Okay. So having valves helps us. Having those valves, and then you squeeze the veins when you contract muscles, are going to work together to force the blood forward. We also have something called the thoracic pump. Okay. Everybody take a big deep breath. Ready? As you take that breath, you expand the rib cage. You increase the volume inside your chest cavity, which lowers the pressure inside the chest cavity. And that lowering of pressure creates a little bit of suction. The pressure is lower here than it is like down in your legs, and it works to try to draw or kind of pull blood from the veins up in. So as you breathe more deeply during exercise, you expand that area. In addition to letting this move more air out, it also helps us to try to drive some more blood back. Okay. So preload's a big one. All right. We have lots of ability to kind of manipulate preload and therefore increase cardiac output. Afterload is not going to be as big a problem in you guys. Afterload is probably more of a problem in me. It's definitely more of a problem in my mom, who has high blood pressure. Afterload is a measure of basically in systolic volume. How much blood is left in the left ventricle at the end of contraction? Afterload, what's left after? Okay. The things that primarily contribute to afterload are how forcefully can the heart contract and aortic blood pressure. Okay. If I make your blood pressure higher than the aorta, then for any given pressure generated in my left ventricle, less blood will move out because it has to overcome a greater pressure. Okay. So parasympathetic and sympathetic input, especially sympathetic, which can raise blood pressure, can affect and make afterload go up. Okay. Other issues, if you have narrowing in some of your arteries and arterioles, you get atherosclerosis, right? As you shrink the vessel down, it raises the pressure inside, making it more difficult for the blood to move. Those things are going to affect afterload. Okay. Big thing. All the things that affect afterload that are not that important for you guys, it's blood pressure. Okay. Another thing that affects it, though, is a way for you guys to really highly change your blood pressure is to do something called the Valsalva maneuver. You guys heard of the Valsalva maneuver? Right? We do the Valsalva maneuver when we lift something very heavy. And you contract your diaphragm, you contract your intercostal muscles, your abdominal muscles. And what we're trying to do with the Valsalva, right, is hold our breath, raise the pressure in here. So when we lift something heavy, we don't squish all of our internal organs. Okay. I'm going to do a squat. Okay. And I've got this big load and these big forces. I need to lock in here to hold posture, but also so I don't like smush my liver and my spleen and my stomach and my small intestine around. So you guys do Valsalva. When you lift something, your blood pressure could be 450 over 300 or something. Really high. When that happens, basically no blood's getting out of the left. Okay, it's so high. That's why. They tell you when you lift weights, you things, you got to breathe. Try to breathe. Because if you're breathing, you can't bounce out. That keeps the blood pressure down. Okay? That keeps the blood pressure down. So Valsalva will increase afterload as well. Okay? Okay. Now think about, I'm doing final. The next thing that affects stroke volume is somewhat related and similar to what happens with preload, because they're related. That's the idea of contractility. Okay? If you think of the left ventricle or your heart as a balloon that has fluid in it, the more forcefully you squeeze the balloon, the more blood or more air or more water will move out. Okay? So when we make contractility go up, we get more blood ejected, a bigger stroke volume. When you make contractility go down, a less forceful contraction, then you get less blood. Okay? So some of the things that are going to affect contractility, a big one that makes it go down, especially as you age, is a loss of cardiac muscle strength. damage to cardiac muscle because of a lack of blood flow that accumulates over time. Someone that's had a heart attack, had some cardiac muscle tissue die. Right? They have a less strong heart, like physically less strong, and therefore they can't contract as forcefully and their stroke volume will fall. That can cause some problems. Okay, I can give drugs. I can give you something like atropine that essentially mimics norepinephrine, and it will make your heart contract more forcefully. I can also give you drugs like a beta blocker, which I forgot to take mine this morning, and it will lower the ability of the cardiac muscle to respond to norepinephrine, and it will weaken that response. Okay, and so where we tend to see issues around contractility, most of the time is going to be it declines in older folks and folks taking beta blockers and other kind of cardiovascular disease medications. And then we can see it go up in response to sympathetic nervous system input in pretty much everybody. And we can see it go up as we get cardiac hypertrophy in response to resistance training. Okay. In addition to when preload goes up, you get stretch, and that makes contractility go up. Okay. Those are kind of the big ways that contractility is going to matter. Okay. So let's just say you are having a heart attack. You have a blockage in one of your coronary arteries. You're not getting enough oxygenated blood to a certain area in your left ventricle. That causes hypoxia. That makes contractility go down. As you become hypoxic, even though we have a whole bunch of mitochondria, we cannot use much air with metabolism to meet our ATP needs. So we start making lactic acid in cardiac muscle, and we become acidotic. Okay. Hydrogen and decreasing pH also decreases contractility. These two things often combine to cause tissue death, which also decreases this. And so this is why the combination of these things in some ways is why a heart attack can be so dangerous. Acutely, you may not be able to contract the left ventricle forcefully enough to overcome aortic pressure and actually circulate blood. Okay. Or if it is hypoxic for a while and you get tissue death, then you have this chronic problem where contractility falls. You guys heard of something called congestive heart failure? It's a disease called congestive heart failure. In congestive heart failure, the left ventricle cannot contract forcefully enough, basically to oftentimes overcome aortic pressure, and therefore you can't circulate blood. It becomes really, really difficult to do that. Okay. And so something we call an inotropic agent, which is basically something that mimics the sympathetic nervous system, that mimics norepinephrine. Those are going to make contractility go up. Those are going to make it go up. Okay. The final piece of the stroke volume puzzle is heart rate. So this may seem a little bit counterintuitive, but hopefully I can convince you guys about why this is really good. Okay. As heart rate increases, the amount of time that each chamber of the heart spins in diastole shrinks. Okay. So at a heart rate of 150 beats per minute, maybe you spend like 0.3 seconds in diastole in the left ventricle. At rest, you might be spending, I don't know, right? 1.5 seconds in diastole. Your heart rate's really lower, right? So as filling time shrinks, our ability to get venous return back to the heart in that amount of time and fill the left ventricle is going to shrink. And in a lot of people, especially low-trained people, when you get to very, very high heart rates, think like 180 beats per minute and over in you guys, okay? We're near like 90% of age predicted max heart rate. Very, very high heart rates. Diastole becomes so short that you cannot fill the left ventricle adequately. You can't fill it as much as you could at 150 beats per minute or 100 or 50 beats per minute. So what happens then is we cannot get enough blood in the left ventricle to maintain or further increase our stroke volume. So at high heart rates, stroke volume either levels off, or in really untrained people, it may actually begin to go down. So as you near VO2 max, stroke volume dips, okay? And that's going to be a predictive factor of why that is your max. Okay? So we can do some things and manipulate kind of what your heart rate is doing and manipulate stroke volume in that way if we need to. Okay, here's some data. And these are actually in the same individuals, but it illustrates the point I was just trying to make. We have resting heart rate or resting exercise, no exercise, we're at rest. We are walking or jogging at 50% of VO2 max, and then we're at max. We're doing a VO2 max test. We're at max here. The y-axis is measuring stroke volume. Okay. My guess is that this was measured with ultrasound. They're doing an echocardiogram, put the ultrasound on, they're measuring sort of blood flow through the aorta. But what you see is, here's stroke volume at rest, 50% and max. The open circles are people when they're not fit. They're sedentary, they're untrained. They then underwent, I think in the study, like 12 weeks of 3 to 4 days per week progressive aerobic training. We make their VO2 max go up, 20–25%. What I want you guys to see is stroke volume increases up to about 50%. And then as we get near max, in the untrained people, it actually falls. And in the trained people, it basically stays leveled off. Okay? So this is all because as heart rate continues to increase, filling time shrinks, diastole time shrinks, and you can't get enough venous return in there to be able to continue to keep our stroke volume up. Okay? That's how heart rate helps us to regulate stroke volume. If we had to kind of boil all of that down, okay? For most of you guys and healthy people, preload, okay? Preload is the single biggest of stroke volume. And we get more preload by having a larger blood volume, by having a larger left ventricle, okay? And by having more venous return, which can be controlled by gravity and posture and muscle tone and those kinds of things. But preload is really the big thing. You put more in, you get more stretch, you're going to get a more forceful contraction, and you'll get a larger stroke volume. Okay. All right. We've got a couple of minutes. Is that clear as mud for everybody? Yeah. If we ask you on Friday, right, to partner up with somebody and start doing things to manipulate their stroke volume, you guys think you can do it? Okay. Well, I don't want to start on the blood vessel stuff. This is a good break point for us. I wanted to tell you guys, as of today, it looks like we're going to push the test back from next Friday, which I think is what it was on the syllabus, where it's listed on Canvas, to the Monday after. Okay, so not quite 2 weeks from now, a week and a half. It's like Monday the 7th or something like that. Okay, I'll change it on Canvas. All right, we'll see you guys on Friday.